Welcome to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I'm your host, Amanda Mixon, the current president of RhAPP, and I'm thrilled to welcome you to the very first episode in our GCA Fireside Chat series. In this series, we're diving into the evolving landscape of giant cell arteritis, a condition that demands timely recognition and nuanced approach to diagnosis and management. Today's episode centers on one of the most critical aspects of care: recognition. How do we distinguish a routine headache from one that signals something more serious? What role do labs, biopsies, and imaging play in pinpointing GCA? And how can we refine our clinical suspicion to avoid missing or delaying the diagnosis? Joining me today are two outstanding experts, Naomi Amudala, nurse practitioner, and Dr. Rennie Rhee. Would you both mind just giving our listeners a brief introduction? Naomi, maybe I'll start with you.
Sure. Thanks, Amanda, for having me on this podcast. I'm really excited to be doing this. So as you said, my name is Naomi Amudala, and I'm a nurse practitioner, and I work at Penn Medicine, which is in Philadelphia. And I'm part of the Penn Vasculitis Center there. I've been working with patients with vasculitis for 16 years, which I can't believe. I started in Boston at the Boston University Vasculitis Center and then moved to Penn about 7 years ago. And it's been a great experience. And I actually have the privilege of working with Dr. Rhee, which is very fun to be in clinic with her.
All right. And I am Rennie Rhee, and I'm a rheumatologist at University of Pennsylvania. Also have the privilege to work with Naomi, who is just extraordinary in terms of her background and knowledge of vasculitis. Also very deep, heavy into vasculitis. Then did a vasculitis fellowship and have a clinic that's very focused on vasculitis. Also, about 5 years ago, started up a giant cell arteritis fast track program at Penn, which has been really exciting and just has been a great place for me to get more experience with giant cell arteritis, both from a clinical realm as well as research. I also lead some research projects looking at vessel wall imaging and giant cell arteritis.
When you say fast track program, what does that entail?
So traditionally, we think of fast track clinics as clinics that are led by rheumatologists who have access to vascular ultrasound, and they can do ultrasound of the temporal and axillary arteries. What we do is a little different. It's really it doesn't include ultrasound, but it provides a system, a process to help other providers, usually primary care, get quick and early access to rheumatology and to other initial diagnostic testing like temporal artery biopsy in a very expedited fashion. So my personal feeling is that really any rheumatologist, even without ultrasound, could develop a fast track clinic and be very successful in terms of improving the care of patients with GCA.
Wow. Well, I thank you both so much for being here. I think you two are just such wonderful experts. And I can't think of, better people to kick off this series. And so right now we're going to unpack some of the hallmark signs and symptoms of GCA, as well as sharing some diagnostic pearls, as well as practical guidance to, how do you confidently identify GCA in the clinic? Because it is true. A lot of people have headaches, and who do you biopsy and who do you not biopsy? So I'm just going to go ahead and start in with some discussion questions. Naomi, let's go ahead and start with you. So what are the hallmark signs and symptoms that should raise a clinical suspicion for giant cell arteritis?
Well, I like what you said about how do you diagnose with confidence, because I don't think you ever do. Very rarely do you have a high level of confidence when you're diagnosing. So just to review kind of on a high level, headaches, jaw claudication, claudication in the arms or legs. So that's cramping in the arms or legs with repetitive movements, scalp tenderness, jaw claudication, so pain in the jaw with chewing. The problem is I was thinking about this, all of these symptoms can be mimics of other things, right? So TMJ, migraines, shingles causing scalp tenderness. And so it is a challenge to try to distinguish what is a GCA headache versus just another headache. One thing I think, and I hear Dr. Rhee asking this as well with her patients, is it new and is it different? And I think that's kind of a very helpful metric to weigh symptoms by. Rennie, I'm curious what your thoughts are on that.
I completely agree. I find that giant cell arteritis can be actually one of the more challenging vasculitides that we manage just because the symptoms are so nonspecific, and our diagnostic testing also has its limitations. But I agree, like the new persistent kind of headache that is not easily alleviated by analgesics like acetaminophen or NSAIDs. That's like the classic GCA headache. But occasionally I see people who, of course, never fit the mold. They decide they're going to present in a more confusing way, and they have biopsy confirmed GCA where they do have headaches that are alleviated by acetaminophen, or they don't have headaches in the temple area. They have it in the back of their head in the occipital area. So I do find that the headache symptom can be a bit nebulous. But one thing that Naomi and I often talk about when we're triaging a lot of these GCA referrals is somebody's coming in with years of headache. It's not really likely to be GCA at that point. You really need to start thinking about other things. And what I find is that sometimes there's like a new provider who steps into the picture and decides to check labs, and they notice the sedimentation rate is whopping high, and that's what leads to this cascade of GCA. But even if you just start from the history and take a really good history, you can already have a sense that, this may be a lower suspicion.
Just one obvious thing also is age. So
Yes.
we get referrals for GCA for patients who are 20 years old. And no, that's not a suspicion when they're that young. And then I think, and I actually am curious what you think, Rennie, but normal acute inflammatory markers are, I think, lower the overall likelihood of GCA.
Yes, totally agree.
When we know there's this association with PMR, so can either one of you, maybe I'll start with Dr. Rhee. What is the association with PMR or polymyalgia rheumatica, and how does this relationship influence the diagnostic approach?
Yeah, they are very closely related to the point that there are some groups, primarily like in Europe, who are arguing for a different naming system, a different nomenclature to actually have a GCA PMR spectrum to kind of really understand and identify that this is really probably one disease that's manifesting in slightly different ways. Kind of the way like psoriasis, psoriatic arthritis probably are very unified. But in some patients, you present with one and not the other. So the percentages are somewhere around 50% of people with GCA have polymyalgia rheumatica, and maybe about 10% of people with polymyalgia rheumatica may go on to develop GCA.
You already kind of alluded to this a little bit. You talked about that sedimentation rate. So which labs do you find most helpful in supporting a diagnosis of GCA? And how specific are they? Because I think this can also be a slippery slope. And I think we've all seen the patients that, potentially come in from primary care already on the high doses of steroids because they had a headache and a high sed rate. And so, I'm interested to hear both of your thoughts on using this as, part of the big picture.
Rennie, I know
Naomi, maybe I'll start with you.
Okay. Well, I was trying to turf it to Rennie, but that's fine. No, so I'll let her talk specifically about the acute inflammatory markers, but I think taking a step back, maybe from a primary care perspective, you would want to, of course, you want to make sure you're not missing anything, right? So you want to check a CBC to make sure that there's no infection and metabolic panel and, a urinalysis because this is an elderly population and could there be a urinary tract infection that's causing some of these symptoms. I think depending on what those presenting symptoms are, if they're constitutional symptoms, fevers, night sweats, that can certainly be GCA. It could also be malignancy or infection. So including SPEP, UPEP, depending on, what the situation is, kind of keeping an open mind to everything. And then this is a really obvious one, but we've seen it before where they're reporting scalp tenderness and you examine the scalp and there's actually is a rash there and it is shingles. And so just a physical exam goes a long way in that sense. And then I do think the acute inflammatory markers are very confusing to people and it prompts a lot of referrals to rheumatology, but I will let Dr. Rhee explain why that's not the case.
Well, I wanted to piggyback kind of on your discussion of the mimics because I think that is really important. And I find that, at least in my rheumatology training, we didn't learn a lot about headaches. We don't learn about headaches at all. And I think that ends up being a challenge because in the world of rheumatologists, sometimes we think headache, we think GCA, but it's important to remember GCA is incredibly rare. And there are similar headache syndromes that respond to prednisone that can also occur and are incredibly more common, migraines being the huge one. And so whenever I take a GCA history, I always ask about migraine type of symptoms. Do they have a history of migraine? And a lot of times they'll say, oh yeah, I had migraine 20 years ago, but this is a new headache, which is possibly still true. They can still get GCA, but it just starts alerting me to the possibility, could this just be a recurrence of the migraines that they had in a different form? Do they have other migrainous symptoms? Do they have nausea, vomiting, photophobia or phonophobia, sensitivity to light and sound? Those are symptoms we would not expect with giant cell arteritis. And, the visual symptoms in migraines are very different from the visual symptoms in giant cell arteritis. And I think this is where I find like a lot of these referrals of headache and blurry vision, again, like kind of going back to the history and getting more details can really help us decide, is this really rheumatology or would they be best served by neurology? So, the visual symptoms in migraines tend to be more positive symptoms. So, like bright lights, flashing, zigzagging lines. Those are, some of the visual symptoms that can precede or occur with a migrainous headache. In GCA, it's a negative symptom. It's a darkening. It's a loss of vision. It's a graying, and it can be transient. It can only last 5 minutes or less. That is much more concerning for ischemic optic neuropathy, which is what we see with giant cell arteritis. So kind of just those little nuances can go a long way. And, just a reminder, migraines get better with prednisone. Tension headaches get better with prednisone. Lots of different headaches can get relief with prednisone. So I don't think that improvement with prednisone alone is specific to giant cell arteritis. On the other hand, a lack of improvement with high dose prednisone should start making you question, is this really GCA or is there something else going on? And the big things, kind of like Naomi was discussing, infection and malignancy are like the do not miss. Also other cranial pathology, stroke, hemorrhage. There's a lot of other things that can happen in these older patients that we need to be considering.
And I think one other thing you mentioned, which is really good, is the response to prednisone. So sometimes I'll see patients and they'll tell me they started prednisone and they felt a little better maybe a week later. And I think that is not what we're looking for when we're looking for a response to prednisone in GCA patients. It should be fairly immediate and quite complete resolution of their symptoms. That's typically what we see. Similar to
Yeah.
PMR, I think.
One other question I had on the, that's all so helpful. How high are usually the inflammatory markers? Because I was always taught, they're usually pretty high, like a sedimentation rate above 50. You start to think more about GCA versus a sedimentation rate of, 25, because, obviously it can go up as we age. Is that true? I mean, do you tend to see them be quite elevated in GCA?
So actually they don't have to be elevated. And I agree that I think that higher numbers do end up prompting more referrals, but we should still be alerted even when the inflammatory markers, the sedimentation rate is even in the 40s or 50s. The challenge with the sedimentation rate is that there are so many other factors that can contribute to elevations in that marker, including age, female sex, renal disease, obesity, infection, other kind of types of inflammatory disorders, malignancies. So it becomes really tricky and non-specific. CRP is, I find, much more useful, and there's actually a lot of data about how CRP is more sensitive than the sedimentation rate in the diagnosis of giant cell arteritis. And this is all assuming before they take any prednisone, which is tricky because by the time they've seen us, they're already on prednisone. So if they don't have a CRP done, it's a little harder to interpret a normal CRP. But when I see normal CRP, again, I start questioning a bit more whether this is giant cell arteritis. Um, in the studies, the large studies that have been done, there was one out of Mayo Clinic. There was another by Tanaz Kermani. There are about, 3-4% of people with giant cell arteritis who ultimately had both a normal sedimentation rate and CRP. And in one paper, they even said most of those ended up having polymyalgia rheumatica. So, I think that basically when they're both normal and the clinical syndrome isn't quite convincing, maybe they only have a headache, but they don't have any jaw claudication, they don't have any vision loss. Really helpful to start thinking, okay, what else could this be? But, in the back of your mind, still kind of thinking about giant cell arteritis. Um, and the other kind of tidbit I would also think about is when there's a discordance, particularly when the sedimentation rate is super high, over 100, and the CRP is normal or barely positive. We see that discordance a lot in people who have false elevations in sedimentation rate due to other things, particularly like paraproteinemias, like monoclonal gammopathies, like MGUS, which also increases in prevalence as in older adults. So people over the age of 50, maybe somewhere around like 1 to 5% have MGUS, and that's going to cause this marked elevation in the sedimentation rate. So again, just kind of helpful when things are normal. I think our suspicion goes lower, but when they're positive, it could be GCA, but you need more diagnostic testing to really confirm it.
Well, let's talk about that. Let's talk about the more diagnostic testing. So obviously, that gets us right into kind of the gold standard, which is obviously that temporal artery biopsy. Naomi, can you talk a little bit about the role of the biopsy and, potentially some of its limitations?
Right. So I think, as you mentioned, the biopsy is considered the gold standard for diagnosis. I can touch briefly on it. The general rule of thumb is that you want to be on prednisone for less than 2 weeks before having the biopsy done. And the reason for that is that because prolonged exposure to glucocorticoids can alter the outcome of the biopsy results. I think the other thing to note is that according to the ACR guidelines, they do recommend unilateral biopsies as opposed to bilateral temporal artery biopsies. We do see a lot of patients coming into our center who have been evaluated outside and have had bilateral And I don't know if that's always necessary. And then just the third thing I'll say, and then I would love to hear Dr. Rhee's thoughts on this, is that I think it is important to make sure that the pathologist really knows what they're looking for, and when they're looking at the results, and also to be open to other possibilities. And again, that giant cells and things that you see in those biopsy results could be mimickers of other things. We've seen some unusual cases there.
Yeah, I totally agree with everything you said. And I do find even the temporal artery biopsies can be challenging to interpret. So, a couple of other nuances or things that I've come across. The first is 100% agreed. Less than 2 weeks is the recommendation. That's in the guidelines. We try to get that biopsy done within 2 weeks, ideally. However, sometimes that coordination of care is very challenging, especially in some areas. And I think that even if it's been beyond 2 weeks, 4, even 6 weeks, if your suspicion is high, there is still value in getting that temporal artery biopsy. There was another study, Connie Wyand and Mayo Clinic, where they did repeat biopsies 3, 6, 9 months. Obviously, each patient only did a second biopsy. They didn't do it every 3 months, but they kind of looked across time to see, in these patients who had positive biopsies at baseline, did the biopsy stay positive 3, 6, 9 months later? And many times they did. And actually, they found like 70% of people 3 months later still had positive temporal artery biopsies. So it was a small number of patients. It's at like one center, and Mayo has this really amazing kind of process with pathology to review these biopsies. But I do think that there is value. So I've come across patients who said, I went to the surgeon to get my biopsy, but they said it's been too long that I've been on prednisone, and there's no value to doing the temporary biopsy now. And I do think that there could have been a missed opportunity where we could have gathered some information. A negative biopsy, I agree, you still don't know, but if there was something there, some ongoing remnant of inflammation, that would have been really helpful. The other thing I would say is that when we think positive, we think, intense transmural inflammation throughout all the walls of the artery. That's the slam dunk, with or without giant cells. That's the slam dunk positive case. There is another entity where they can get a little limited inflammation in the small blood vessels around the artery and in the layer called the adventitia. So some terms that are used for this is called kind of adventitial inflammation or vasovasorum vasculitis or small vessel vasculitis in the vasovasorum. If you see that, that could also be giant cell arteritis. It could be either an early sign of giant cell arteritis or a partially treated giant cell arteritis. And so that should, still alert you to the possibility. Unfortunately, other things can cause that as well, including infections and malignancies. So it's not, specific to only giant cell arteritis, but certainly is seen.
Wow, that is so helpful. I didn't even know all of that. So again, I really appreciate both of your input on that. How often do you see where the biopsy is negative or they like missed, because I've heard this also where it's like, well, they could have just missed the spot of inflammation. Is that true?
Go ahead, Rennie. What do you think?
Okay, yes, definitely, definitely. There is a sampling error that can happen, and unfortunately, some of the imaging data, which we'll talk about in a bit, but has shown we've found with our MRIs that around 10% of people don't have any temporal artery involvement. They have other arteries in their head that are inflamed, which could explain some of these biopsy negative patients, but also just the patchiness of the inflammation. If we just didn't get the right spot, we can miss it. So it can be very challenging. Negative biopsy can still be possible in someone with giant cell arteritis, but you just want more convincing clinical, manifestations that, you know, put more confidence in giant cell arteritis. So I often see these kind of second opinion cases of patients who were diagnosed with GCA years ago. And, there's still some question. Their biopsy was negative. There's still some doubt. And I think the hardest thing, we always say this in our clinic, the hardest thing to do as a rheumatologist is like not to treat, right? We don't want to miss giant cell arteritis. We don't want patients to go blind. But there are some patients where the probability is low and the toxicity from steroids is so high that at some point, you make a decision, share decision making with the patient, where you agree, let's try coming off the prednisone. If your headaches come back, let's talk with your primary or neurologist, find some alternative solution to manage the headaches, but always be monitoring for that vision loss. That darkening in one eye or both eyes can be transient or double vision. If that happens, all right, we got to go back up on the prednisone. That's the thing that we don't want to miss. That's what we're all worried about. But other than that, let's see if we can try to come down on this and reconsider and reevaluate the situation. I've definitely seen these cases where we have successfully come off prednisone and patients feel so much better now that they're not on prednisone and their headaches are not coming back. So I don't know, did they have GCA and now it's just in remission, or did they never have GCA? It's hard to know, but I think it is important for kind of the well-being of our patients to always be, working together to reevaluate these situations if we are doubtful of the diagnosis.
I think it does take a certain level of confidence to not treat, especially when it comes to giant cell arteritis, because that threat of vision loss is always hanging over you. And it's just sometimes it's more comforting for the provider to just keep the patients on the medications because nobody wants to be responsible for vision loss.
I think that's the hardest part, and I when I see a patient, if they are uh, pretty reliable and they've got a great support system, those are the patients where I think really great counseling and just letting them know, look, I'm not sure. This is a symptom we don't want to miss. This is what sends you to the emergency room. I tell them, pop 60 of prednisone, you're getting vision loss. You pop 60 of prednisone and you go right straight to the ER, and you can call me on the way there, but you don't wait for me to call back because we don't want to miss that. And if you get 1 or 2 extra days of intravenous steroids, it's not the worst thing in the world. We just don't want to miss, we don't want you to go blind within hours or days. But a lot of times, as long as patients are comfortable with that and they can be educated, I think that we can do a very gradual coming down. I really think it depends on the situation and on the patient and what they're comfortable doing.
So the last piece of this, and I think this will be really helpful for our listeners, we're hearing all of this, do you, instead of a biopsy or in addition, imaging, maybe we don't need biopsies. Maybe we can make the diagnosis on an image. So Dr. Rhee, can you just touch on MRI, PET scan, ultrasound? Like, what are you using? Are you replacing, a biopsy with one of those modalities, and why, or why not?
Yeah. This is a really exciting era for giant cell arteritis. This is what I love about research because we're really making changes that I think have a great impact on patient care and can do a better job. I mean, I can't believe like 50 years, all we've been doing is temporal artery biopsy. And it's not a perfect test. And now to have the opportunity, instead of visualizing 1 or 2 centimeters of an artery, to be able to visualize the full length of the artery and multiple arteries all in one scan, I think is really revolutionizing our ability to diagnose the disease. I think the caveat, though, is that this needs to be done in the hands of skilled operators and whoever is interpreting it, right? Whether it's the rheumatologist interpreting the ultrasound or it's the radiologist interpreting the MRI or the PET scan, that expertise and experience in Janssen arteritis and in vasculitis is critical, and that's what's often lacking in many centers. And so I think that as more and more research is coming out, people are hearing more about this. It's getting implemented more. This will, foresee, will certainly become more available. But it's just finding the right center, the right people to do it. I will start with ultrasound. So ultrasound is, I think, has so many benefits to it. It can be done in the office at the point of care. The patient comes in, they're not on prednisone. A rheumatologist who has the experience doing this can do the ultrasound right then and there. And in the hands of a skilled operator, really excellent diagnostic accuracy. And in those centers, it is starting to replace biopsy. There are a lot of algorithms that are available in which, based on the clinical history plus the ultrasounds in terms of like how many, what's the score on their ultrasound, how many arteries were shown to be abnormal, they can come up with a probability score of whether they have GCA. And then additional testing like biopsy can be done in the subset of patients where you're still need more additional evidence because you're not very certain. But I think this is great. It's a lot more comfortable for patients. Um, so I think, and now there's more data even coming up in terms of following these patients over time for treatment response using ultrasound, and the ultrasound demonstrating there is some improvement in the arteries over time. So I think this will increasingly be used. I think if in the U.S., if we can get more and more providers to do the appropriate training and get the experience, incorporate it more into training programs, I think that this will have a lot of value. The challenging thing, though, unlike musculoskeletal ultrasound, is that GCA is very rare. Like many of us will see a case. Well, maybe not me, but most rheumatologists will see a case or two of rheumatoid arthritis a day, right? So doing a musculoskeletal ultrasound and getting that experience is very easy. You're going to get, within a few months, get a lot of cases of true inflammatory arthritis to feel confident with your musculoskeletal ultrasound technique. But with GCA, I mean, maybe you might see one once a month, if that, maybe once a year. And at that rate, having enough experience with ultrasound to feel confident, I think, will be more challenging. MRI is what we have been using at Penn. I personally, and I just think it's so valuable in several ways. I think one, it's actually very easily accessible to any specialist. So, a primary care provider, a neurologist, rheumatologist, they can all order it. There's no funnel in terms of trying to get into rheumatology in order to get it. They can all order it. They can usually get it within 2 weeks and have some information. The other thing is that the MRI can look at arteries beyond the temporal arteries. It can look at the vertebral and the occipital arteries. It can look at maxillary arteries, which are the arteries that can supply blood to the jaw muscles, which contribute to jaw claudication. It can look at the arteries that supply blood to the eyes. There's a lot of information, and we are in a multi-centered group. We are studying this to better understand how does all of this information from all these different arteries, even in the eyes, how does that help us not only diagnose, but also be able to predict outcomes like vision loss or relapse? Or can we use this longitudinally to monitor treatment response? The other thing that is useful about MRI is that it rules out other, do not miss mimics of GCA. So the stroke, the hemorrhage, the mass, those things in an older population that can cause new-onset headaches, elevated inflammatory markers. We can also, in that same scan, be able to assess for that. And occasionally we have come across that where it's not GCA, but it was something else that we were then able to refer them to the appropriate specialist. So that's ultrasound MRI. I'll let Naomi talk about PET CT. That's a whole other.
So PET CT, I think even just in the 15 years that I've been in rheumatology, I've seen an uptick in ordering. We definitely were not ordering as much 10 years ago as we are now. And I know that it's really dependent on who has access. Not everybody has access to PET. So it's really nice that we do. And we're ordering it more and more, basically in any patient that we suspect has large vessel vasculitis, especially if malignancy is on the diagnosis or differential diagnosis. I can just think of, 5 patients off the top of my head, that elderly patient with significant constitutional symptoms, some headache, very high acute inflammatory markers. And yeah, you worry about malignancy, and we do get PET CT scans on them in addition to cranial MRIs and everything else. And we're looking for large vessel involvement. We're looking for increased FDG uptake. And as Rennie was saying, it really depends on who's reading these scans as well. And can they differentiate between atherosclerotic disease versus actual vasculitis? But a lot of times it's helpful because you don't know if the disease is active or not. So they may have some kind of a narrowing or a stenosis in a subclavian artery. Maybe they've had that for years and years. And so getting those PET scans can give us some information and really guide treatment. Yeah.
Wow, that is so helpful. So maybe some of this imaging is not quite yet for prime time. I mean, what I'm definitely hearing you say is this is super exciting, and definitely you're utilizing these modalities, but we really need to make sure that who is performing the exam and who's reading it really knows what they're looking at, because, again, if not, then you could miss it. That's what I heard, I think, from both of you. And I know in my clinic, it's really hard to get PET scans. And so, but again, I'm excited to where where GCA was 10 years ago to where it will be 10 years from now. And I think hopefully at that point, we'll be utilizing it. So on that note, that brings us to an end of this first episode in the GCA Fireside Chat series. A huge thank you to Naomi and to Dr. Rhee for lending their insights and experience that I know will just be invaluable to our listeners. I know I've been doing rheumatology for 18 years and I learned something. And so I just so appreciate you both being here. If today's discussion sparked new ideas or raised questions, we encourage you to continue with the conversation with your peers. You can go to the RhAPP ACE 2.0 app community forums to do that, and all of our other, we're on social media, etc. Stay tuned for the next episode of our GCA Fireside Chat series, where we're going to explore current approaches to managing GCA from both steroids to steroid-sparing agents and beyond. Thank you so much to AbbVie for their continued support of APP education. As always, thank you for listening to RhAPPcast. Be sure to subscribe so you don't miss the rest of this impactful series. Until next time, I'm Amanda Mixon. Take care.